is what I do, why I set up my practice this way, and how I did it, and some of the challenges we face that I learned along the way, and what I think the future holds for us as radiologists. Hopefully, it won't take too long, and we have lots of time for questions. And this is it's an ongoing discussion, really. What I do, as Jason said, I'm a diagnostic neuroradiologist. I'm not an interventional neuroradiologist. They do the fancy, thrombectomies and coiling, right? Very high level work. I do diagnostic, which is we look at images and we provide our interpretation. I did med school in Alberta. I grew up in Ontario. Went to med school in Alberta. Came back for residency at Western. Went all over, and my radiology training was done at here in McMaster, where I'm now working. In between my fellowship, graduating my fellowship, and coming back, I did 2 years, worked 2 years at Hamilton, sorry, not Hamilton, Health Sciences North in Sudbury, which is a hybrid of community and academic practices. And I did work there for 2 years, which was great community, great hospital, great people. But unfortunately, it was a little too far for me, and there are some other factors that contributed to me coming back. And I'm now at Hamilton Health Sciences, and I work at the Hamilton General. We're separate radiology groups in each hospital. And I've been here for 2 years. And so far, it's been 80% of my practice, but 20% is doing radiology experts. And actually, it's going to become 60-40 Hamilton Health Sciences, and 40 radiology experts, because it's taking up more and more of my time. And it's something that I want to grow. So what I do at Radiology Experts is it's a subspecialty radiology second opinions service. It is publicly funded, and basically take requests for second opinions from physicians and patients. And we provide our own second opinion radiology report in return. And that's the long and short of it. And how I got started was after I graduated, I started helping out a friend who's a neurologist in the community. And she didn't have access to, she didn't know any other neuroradiologists. And obviously, she deals with brain and spine, being a neurologist. And so she asked me for help, and I was able to provide some diagnoses, some interpretations that she wasn't getting from the community. And she referred me to other neurology colleagues of hers, and I got busier and busier, and decided to kind of make this part of my practice. Initially, I had a pretty janky setup. Like, I looked at images on Clinical Connect. I don't know where you guys are, but in Ontario, we have this provincial portal called Clinical Connect. And in some parts of other parts of Ontario, it's Connecting Ontario. I think the viewer is similar, if not the same. They work similarly, where you have access to almost every other institution in Ontario with access to the images and clinical data, which is very nice, but slow, clunky, and sometimes doesn't work. And I didn't have a PACS, right, which is what radiologists really need to look at their images, and didn't have reporting software. So I typed up my reports on Google Drive, on Google Docs, and sent it out, or faxed it out. I had emailed the fax service. But as I got busier and busier, obviously, I had to set up some form of infrastructure, dedicated infrastructure to do this. And other radiologists who had from other subspecialties also approached me and joined me to provide this for their own referring doctors. So my first partner was or is a MSK radiologist, and he does amazing work for his orthopedic surgeons and sports medicine physicians. And now we have about 30 radiologists working together. So it's a pretty unique practice, and it's growing, which is very nice, and it's been very fulfilling. The reason we need, I think, second opinions is this isn't black and white. It's a bit of a spectrum. In radiology in general, and I'm pretty sure there are parallels in other specialties and not just radiology. We have general versus subspecialized radiologists. Shouldn't be versus, should be general and subspecialized radiologists because we're working together. We each play very important roles in the system, but I think there's value add that we can offer as subspecialized radiologists because we have access to a lot of data by nature of what we do. And to not take advantage of that, I think, is a missed opportunity. So in general practice, it's mostly general radiologists who've done 5 years of radiology training. They go into practice. And a lot of these types of practices, they interpret X-rays and ultrasounds and maybe CTs and MRIs also. They don't tend to be as complex. They're from smaller communities. And every radiologist reads everything. X-rays, ultrasounds, CTs, MRIs of any body part. And the Royal College says that they are by Royal College standards that if you graduated from a residency program, passed your Royal College exams, that you are competent in reading all of these. In subspecialized radiology practice, we have radiologists that have done extra training, 1 or 2 years of extra training in an accredited program, and mostly from North America, if not from the UK, and may have written the Royal College if it's offered in that subspecialty. So for neuroradiology, let's say, we do have another exam that recognizes your training and expertise in neuroradiology. And then you also work in a setting where you do almost your subspecialty or your subspecialty almost exclusively. So 90% of my time is spent looking at adult brain and spine. And again, it's not black and white like this. There are community centers. Of course, centers that have subspecialized radiologists tend to be in the bigger cities and the bigger hospitals. But there's a big spectrum. There's community centers, more and more, it seems, that have a subspecialized practice within their radiology group. And perhaps the radiologists aren't reading everything, but they're reading a smaller number of other specialties. So where we can offer a lot of value is where the general radiologists or the radiology in the community setting who've encountered studies that are outside of their comfort zone, outside where they have done a lot of training, right? So for the higher level CT and MRI brain and spine cases, we encounter a lot of rare disease in anywhere, actually, in medicine. But in radiology, when a general radiologist encounters that, they typically provide a broad differential. The clinician has to work that up, spend a lot of time, and I'm sure a lot of resources, a lot of our public resources, work that up to get to the right answer, and eventually the patient gets referred to a larger center, and so on. But because the data was generated from the community, a lot of times when we have the patients referred to us, by the time the patient is with us after a few follow-up MRIs, we look back on the initial CT and MRI. And in neuro, we just deal with CTs and MRIs mainly. I realized that we could have given the right answer without all this workup from the first one, right? And that's where I think we can add a lot of value. But it's challenging to streamline this process, of course. Why we do it, again, it speaks for itself. We can get to the right answer faster. It improves patient care. It saves costs. because we can save clinicians the time and energy and the system, the money from having to work up, right? These for unnecessary possibilities and unnecessary diagnoses. It also allows subspecialists to do more of what they want to do. So I only want to look at brain and spine. I train in this. I love my job, and especially my subspecialty. So I want to do more of it. And this is a way to do it. For some subspecialized radiologists, they want to do more of what they train, but it's just not available. And so they have to go out into the community, right? If they have the time and energy to work more and to increase their income, they have to go into the community. So I see this as a way to offer those radiologists an opportunity to just do more of what they love. It also improves the should say radiologist improves the expertise of the subspecialized radiologist because it broadens my referral base and it gives me exposure to way more complex cases than I would have otherwise been exposed to. Even at the Hamilton General, we're a quaternary care center. We have a lot of interesting cases, but even then, I'm encountering cases from my second opinion practice that would have taken me years and years to have seen. And at the end of the day, it makes me a better radiologist, and I love that. How do we get paid? In Ontario, we're very lucky. We get paid publicly. There is a code in our schedule of benefits specifically for second opinions. But outside of Ontario, unfortunately, we have to charge privately. We don't have that much demand from outside of Ontario. No one knows about us, even in Ontario. But especially outside of Ontario, we get very few cases. But the reason is, we have a publicly funded system, but it's divided by provinces, and there's nothing in the fee schedule in any one ministry that allows remuneration of a physician when the patient and the physician are in different provinces at the time of care. So when the patient is from another province, but they move to Ontario and they see a doctor, they have a BC health card. The doctor having the patient in Ontario can charge BC, can bill the BC ministry and get paid. But if the patient is in BC and asks the doctor in Ontario for their time, for their expertise, the BC ministry is going to say, and we've tried this, well, the doctor is in another province, we're not going to pay that doctor. And then when the doctor in Ontario tries to bill the Ontario ministry, the ministry says, well, the patient is in BC, we're not going to pay you. So this becomes an uninsured service, which means that we have to bill privately. And it's unfortunately, it's just not recognized as kind of practice where the patient, I guess the ministry didn't know about radiology when they set up the rules or the Canada Health Act, and doesn't remunerate for this very specific interaction. How do we do it? Again, we needed PACS and voice recognition. So it looks easy, but it took me a year to set up, mainly because the PACS vendors, the PACS that have the features that I need, they deal with bigger facilities, bigger institutions, and they don't really care about small practices like me. So I went to the big names. Of course, I only knew about them, right? Like Agfa, Sextra, Merge, and I asked to be a customer, and they would ask me, "What's my volume? How many hundreds of thousands of cases do I do per month?" And I said 5. They said, "Oh, great, 500,000 cases per month. That's great." Um, and I said, "No, just five, like one, two, three, four, five." And then that would be it. But they sometimes don't even return my emails after that. So fortunately, they need economies of scale in order to even service customers. So it's been a challenge finding even small packs that would take me on and has the features that I need. And luckily, I found Konica Minolta that has a PAX, and they've been a great help. And voice recognition is Fluency Direct, just for your interest, which I love. Um, so the process is the clinicians send us a request for second opinions, mostly over fax, which is crazy. We still use fax, but that's our system. Um, we look up where the images are on Clinical Connect, and it's my assistant does that. We find out where the priors are that we need to import. And patients move around a lot, of course. So we could have an MRI from, Markham, and then a CT from Windsor, right? And very likely that we have Clinical Connect that we can even see these images or we can see that where they're from. And we send out requests to these individual facilities for their cases, for their images. We need the native, we need the DICOM files to import into our packs, right? So that we can view them conveniently. Again, Clinical Connect, unfortunately, gives us access to the images. We can do it if we have to, but it's just too clunky, unfortunately, and slow. Once we receive the images, that takes about a week or two, sometimes even longer. Sometimes by CD, even though we have the internet. And surprisingly, by large institutions also who insist that they send by CD. And when the CD isn't broken by the shipping process, we use our CD drive that I bought from Amazon because you can't get it from anywhere else that I know. We import it into our system. When it's online, it's great, right? And make it available to our radiologists to report. By the way, Pocket Health has been an amazing help for this. Our requests and importing system is done by Pocket Health, and they have a product called Image Retriever. Obviously, they service patients in hospitals, transporting between hospitals and patients in hospitals. But they also facilitate transfers from solo practices like mine, and have been a godsend. Without them, it'd be a much slower process. And once we finish our report, we send it out also by fax mostly. So that's the process. It takes about 1 to 3 weeks, sometimes longer, depending on radiologist availability, and depends on the urgency. We're getting more and more urgent requests now, where I have to use Clinical Connect and just send preliminary study, not a full official study, but at least it gives them the answer. It gives my clinicians something to work with, some help that can speed up the care of the patient or expedite the care of the patient. Challenges we face, obviously, PACS is a big issue. Took a long time to solve. Access to images. So in Ontario, our imaging archives are 3 separate archives that sort of talk to each other, but not really. Like if the patient is from Oakville, I would have to, I think they send images online, but it's not an easy process, right? As opposed to Burlington, where we have relatively easy access, just because we're in the same LHIN, right? Same region, one of the 3 big regions in Ontario that Ontario has been divided into. And yeah, it'd be nice if we have one archive for the entire province, and hopefully we'll have it one day. Knowledge of service. So no one knows about us. See, some people know about us, our clinicians do. But I love for more clinicians to know about our service, to know that this exists. A lot of time when I tell clinicians about our service, obviously they had no idea they could even do this, or that it exists. And it's inconvenient also, even if they do want to refer to us, because it's a separate process. It's not as easy, and they're not used to referring to a service like mine because it's relatively new. So they do need to take some time. Adequate remuneration. I'm having a challenge recruiting amazing radiologists because they're busy enough with their own practice, and I'm trying to convince them, hey, you want to do more work in your own subspecialty, more interesting cases, broader scope, and so forth. And compensation is a factor, and it's the remuneration we get from the ministry. It's good. Obviously, it's good for 30 radiologists that I have, but I think it could be better. I mean, everyone wants to get paid more, right? Subspecialists, radiology's availability related to recruiting radiologists. A lot of radiologists that I've approached, they've carved out their practice and they've been working there for a number of years. And the better radiologists tend to be mid to late career, also because they have so much experience, right? But there are amazing radiologists at all levels and practices. But for the ones that are mid to late career, they're used to their practice, and they've carved out exactly how they like it. It's tough to convince them to add something else to change it up. Group politics. Some radiologists have told me that their group doesn't allow them to work for another radiology group. They said that they could work at McDonald's, but if they do any kind of radiology, they would have to, because of their contract, they have to pool their income from the second group into their main group, which makes it not worth it for them. But they can keep all the money they work that they make from McDonald's. So those have been the challenges. But despite that, I'm very thankful that we have still a few radiologists that are willing to join me on this venture. How do we help small communities? One archive for the entire province would be amazing, because then we wouldn't have to send out requests. There doesn't need to be a person receiving a request for images. We can just go out and grab what we need. Hopefully this happens one day. Convenient method for radiologists and clinicians to refer to another radiologist. So clinicians can refer to other radiologists, the ones that refer to me obviously know about this. But it would also be helpful for the radiologist to also refer to another radiologist. It happens, but very rarely. Where this kind of practice is quite common is in pathology, actually. And it makes sense because pathologists, a lot of the time, like, the buck stops with them, right? After you get a brain biopsy, you need to give, as a pathologist, you need to give an answer. If you don't know, no one knows, right? What's going on with the brain or with that pathology specimen. We should have more of that attitude in radiology, because it's non-invasive. Fine, you can get a biopsy if we don't know, but it's a lot of time it's not possible to biopsy, right? Not possible to sample or to render the tests. Radiology, in some cases, the imaging is the best that we can do. And when that happens, I think the radiologists need to take on that kind of attitude that is more common in pathology. The buck stops with them. Can't give an answer that has 5 different possibilities. You need to give one. If you don't know, you find someone that knows. So I'd love for this kind of culture to change in our, or this this to change in our culture. Um, and it'd be nice for the ministry to incentivize this kind of practice also. There's no incentive right now, aside from the radiologists just wanting to do a good job, which there are plenty of. But it would help this kind of practice if there are incentives in the ministry. There are things like this in the ministry that do incentivize referrals, that do incentivize second opinion requests, but not for radiologists, or at least it's not very easy. Future direction, where I see radiology going. Radiology is going to become more specific, more data driven. So I know this because the questions I get from my clinicians who refer to me for second opinions, they ask questions like, my radiologist told me it could be one of these three things. Which of these three things is it? Right? I need to know one of them, right? Which one is it? Because I can't work them up. There's no other way to exclude, right, these abnormalities. The clinicians are also more, they have more and more expertise in imaging. Stroke neurology, which is a branch of neurology, for example, they have in their training requirements, in their Royal College requirements, imaging expertise. If the stroke neurologist doesn't know how to interpret their own images to a certain degree, they wouldn't be recognized, right, as a proper stroke neurologist, right? It's part of their requirement to know how to interpret images. We're seeing more and more of that in the non-imaging specialties. Some ENTs I know, otolaryngologists, they tell me they don't even read the reports on their sinus CTs that they order in the community. They interpret themselves. They do read the reports of head and neck neuroradiologists, though, from academic centers, right? Just for the record. So there's more demand from clinicians, right? They want greater specificity, and it's going to be more data driven because of AI. I'll show an example in the next slide. But AI is going to allow us to see garner more information, extract more information from the images that we get. And the imaging technology themselves are becoming better and better, right? Every year, we're able to see more and more, which means the demand for us to interpret those abnormalities is increasing. And because of all these advancements, and of course, we're always adding to the pool of knowledge, medical knowledge, I think eventually we're going to be more and more subspecialized. So right now, it's not a requirement to, be a subspecialized musculoskeletal radiologist, right? To read an MRI of the knee, for example. You can graduate residency and read MRIs of the knee. But I think in the future, there may be a time when you do need to be recognized as a subspecialist in your area to read the body part that you're reading. It's sort of like internal medicine. I'm sure there was a day when everyone was an internist, right? Internal medicine specialist. But now we have hematologists, rheumatologists, right? Intensive care. And they each have their own dedicated stream of training. And if you didn't train in hematology, you can't. Well, I think actually you can in the smaller communities, but medium to large communities, you probably can't do hematology. So radiology is moving in that direction. And we can probably say the same for many other specialties in medicine. And this is an example of an AI report generated by this company called Combinostics. We see there are a lot of these companies out there now, a lot of them coming from Europe. This company is from Finland. And these type of reports are very similar. They give us volumetric data. They tell us the volume of each part of the brain. And it's very useful for neurodegenerative disease, where we need to know, is there enough atrophy for us to call the particular neurodegenerative process that's causing dementia. Of course, the most common one is Alzheimer's. And then the most important feature is hippocampal atrophy. One of the most important ones is hippocampal atrophy. And not only tells us the volume, the exact volume of the hippocampus, right here, it tells you, on what, in what percentile, it gives us normative data, right? Where on the spectrum do you sit compared to other patients of similar age? Or in this case, this patient is on the first percentile, so severely atrophied. Now we can probably tell by eye that there's significant atrophy, but it's we wouldn't be able to say specifically, right, or definitively for borderline cases. So this helps a lot in this regard. And this is just dementia, but we can use this type of analysis for many, many other branches of radiology and medicine. And we're going to see more of it. Unfortunately, these tests they're pretty expensive, and no radiologist is going to pay $60, right, for this report out of pocket. It has to come from the system. But we just had a meeting with our hospital 2 weeks ago, where the administration told us we're broke. And they said that's okay because everyone else is broke. So there's no money in the system, unfortunately. And second opinions, we could take a portion of that and dedicate it to reports like this that can just offer more value. And where we're not sure, and the patient goes on without being treated, we can offer more definitive diagnoses sooner, which is always good. So that's where I see radiology going. And thank you again, Jason, and everyone, for your attention and for the invitation. And I welcome questions.
Thank you very much, Euan. This was a great discussion. If you don't mind, I'm just unsharing your slides. I'm going to share some concluding thoughts, and while we ask you some questions here. We'll go in order. There were some that were direct to me and some that were in the public forum. This one was from David Kwan. So Dave, if you want to expand on this, you were talking about hinting at how it was difficult to streamline the process. So can you expand on that?
Which process? Sorry.
So Dave, if you want to.
Yeah, that was Dr. Zhang, that was early on. And I think you answered some of them in some of the slides and challenges that you met. But overall, I'm going to pose that question a different way. In terms of importance to you, what are maybe 3 things that could be addressed to streamline, the whole process of giving you, like, I view your service as being like a referral from a clinician. And in at least in Ontario, there are guardrails around who you can refer to and who not to refer to. But I think you got Charles Pariseau here on
Yeah, it's just for next week. Yeah, we can have the questions while that's
so maybe just hint at the top 3 things that you feel could actually be alleviated to kind of streamline the process. This approach.
Right. One is, okay, you're asking about the process. I would say above that, the most important thing is the culture. So for radiologists to not just provide their best opinion, but to provide the best opinion possible on the images. If they don't know the answer, and it's possible that a subspecialist radiologist could provide that, I would hope that one day it becomes regular practice that they seek out, right, a more trained, more specialized radiologist, and more routinely. But after that, though, the process has to be easy, or else no one's going to do it. And right now, because we work in PACS in our, speech recognition, we have our HMRs like Epic. There's no function within our infrastructure to send out these requests, and not even to, other clinicians in our other radiologists in our city, but and especially not outside of our system. So it's very challenging. Like it would have to be informal, right? If I want an opinion from, I mean, for my colleagues, we have a WhatsApp group, so that's easy. And most of the time, almost every time I get the answer I need. But let's say I need a highly specialized opinion from Toronto or anywhere else, I'd have to know that radiologist, send them an email, right? And ask for the opinion. And it'd be nice to just have a central service where we have access to any subspecialized radiologist and in any branch of medicine, actually, who can then in return have access to the images that they need to provide that opinion. So we don't have that now. And the third thing, I mean, the second one is a pretty big one. So the third thing I'll say actually is that one of my clinicians said, I don't want to be the only one reading your reports. I want your reports to be available to all clinicians who are looking after this patient. When we send out reports, it just most of the time they put in their EMR and that's it. It's not connected to Clinical Connect, right? So it's not available by other clinicians. And it makes it a lot easier. It makes it a lot better for patient care too when all of our data is available to all the clinicians and healthcare workers for that matter in the patient's circle of care. So that's another thing that I hope one day could happen.
Brighter days are ahead, I'm sure.
Yes.
So there's a question from Don Dennison, and he's asking about accepted statistics around like from a reliable source that would demonstrate the difference between exams read by a subspecialist radiologist versus general, and what does this lead to better outcomes?
Yeah. Yeah. Great question. You know what? Most reports I see in the community are very good and they answer the questions that are asked by the clinicians. It's the ones that are complex that are outside of the areas of expertise of the community radiologist or any radiologist that I see some discrepancies that I can add some value. There are lots of papers actually published that discuss the statistics of the discrepancies around the discrepancies between subspecialized reads, second opinion reads to the initial report. In general, it's about depending on the paper we read, about 10 to 30% of cases that are read in the community can be, that there is value add by a subspecialist radiologist. And within that, some are minor and then a small proportion is major. So it's definitely, we shouldn't be reading all cases from the community. First of all, we don't have enough radiologists, but it's the complex ones. And, by and large, the reports are not just, good from the community, adequate in most cases, but the ones where even the ones that I've added suggested different diagnosis, or narrowed down the few diagnoses that were offered to one, the initial radiologist was able to see the abnormalities. So detection of abnormalities is not the issue. It's the interpretation of it and to offer a more specific interpretation on top of that. So it's definitely a small percentage.
I'm curious. So piggybacking off that thought around the role that specialization plays, and you had mentioned kind of it was improving the subspecialty expertise. Did you see it going the other way? Did you see that the community radiologists were now, as a result of getting this record back, and they're able, or was that a metric that was looked at all as far as how the community was impacted?
we don't get enough requests from radiologists to know, but it stands to reason that they would, right? If they were to work with us for an extended period of time. Our most of our requests, the vast majority, are from clinicians. Unfortunately, most of our reports don't make it back to the original radiologist. Some radiologists have requested it. And for the ones I know personally, I do send it back. And really, most of the radiologists that asked from the community that asked for my help are my friends, the ones I knew from training. So I send it back to them. But the ones who I don't know, radiologists are hard to get a hold of actually. So it doesn't make it that much easier being another radiologist to get a hold of a radiologist. So I just don't have the time to send it to them. The other thing is a lot of rare disease, even for me at, quaternary care center, it takes a long time to even see one of these entities. It could be a lifetime for a general radiologist, community radiologist to see one of these. So it's not like they're going to see too many and they may never see it again. So then, and also they need to be doing this constantly. They need to be looking at brain scan to really appreciate the subtleties sometimes, so to get the benefit of the an interpretation by another radiologist. So the benefit, I don't see it being there worth the effort to go chase them down and to give them this feedback.
Okay, thank you. Next question, and you've touched on a little bit around this, but if maybe we can go a little further. The question was, why isn't eNITS being able to help you with this, or the connecting one, the provincial viewer that's in place today? And I understand. I think eNITS is specifically emergency, so there's probably cases where you're outside of that. But yeah, how do those type of assets fit into the workflow, and are you able to leverage them at all?
We approached eNITS, but they declined to allow the transfer of images. So for radiologists to be able to do their work and to be remunerated for their time and expertise, which is for anyone a very important part of doing a job, the images need to be imported into an accessible PACS, and for that PACS to be connected to some sort of reporting software. And eNITS just allows us to look at the images and provide an unofficial opinion, right? And it's mostly used by, I think, telestroke neurologists to just get access very quickly. Again, they have, imaging interpretation expertise. But for neuroradiologists or radiologists in general to report on that, it's very, very difficult. You may as well just request the images themselves. So we do use it, for my neurologists who need an urgent opinion. I've had to use it sometimes, but unfortunately, we can't scale our practice with eNITS. They don't transfer. They've unfortunately declined to transfer images, and then also some cases like we have to call the source facility to put it up on eNITS, not automatic. And then, sometimes it could be a challenge to get a hold of the CT tech to, import the images. And it takes some time. We got to wait now for them to have the time to import the images. So it's cumbersome. That's another contributing factor.
And so in your setup, when you were evaluating different PAC systems, and when I thought of this, I thought of Mohamed, who I see in the audience. Did you explore the option of going open source, using any
Yes,
open
but
source options?
yeah. Oh, yeah. I mean, a lot of what we use now, I was told, it comes from, what was once open source or open source data that has been adapted. But there's
Yeah, a
a ton
lot
of
is
stuff.
built on like DCM for Chi, for example. A lot of PAC
There you
systems
go.
are that's a foundational.
There you go.
Um,
Yep. I have approached some developers and they said, no, it's still gonna take a long time to get you all the tools that you need. And so it turned out to be just more efficient, cost effective to go with an existing vendor. Had I not found one, I would have gone to a developer. But having said that, now I'm working with a small PACS vendor who is adding all the features that I need that was missing in Konica, which I'm very excited about. So I'm getting a bit of both.
It's always nice when the vendor's hungry, um, when they're full and they like when they want more sales and so on. So and
Oh,
you
yeah.
know they want some
Exactly.
business. That's good.
It's the exact opposite of my experience with the big vendors. The big vendors, like they don't even return my emails when I'm not a major hospital. But this one says, okay, what do you need? I'll build it for you. You can help me grow my business. You can help me improve my product, right?
I'm curious as far as the um, amount of information, the study type of studies that your practice is looking at. How much would you think that is covered by cancer? How much of it is cancer imaging?
Right. It depends on our referrers. We don't have a big referral base from the radiation oncologists, but I would love to help them too. Um, but from the neurologists, not that much. If we have a big referral base from neurosurgeons, it would be quite a bit. It's a small percentage, mostly when it's neurologists or from general from family doctors. It's a lesion that was called a potential tumor that we have to rule out. But if we were to get more referrals from radiation oncologists, neurosurgeons, medical oncologists in that area, specialties that obviously deal with cancer, the questions would be, what type of cancer is this? Is this benign or malignant? Do you notice any features that could narrow down the genetic subtype, for example? Yeah.
Well, thank you very much. This is good. I think we're at a racetrack as far as the questions go. I just wanted to take a few minutes. Just we've been staring at Charles' face here for a little while. So our next webinar on November 15th, 12 p.m. to 1 p.m., and that's Eastern. We're going to be looking at chartering interoperability for large-scale second-generation imaging, and there's some really interesting efforts that Charles is putting forth, and Alain, the co-chair of the group, has been actively involved in this. So hope that you can join that. You'll get notified in all the normal ways you always do. And other than that, I hope everyone has a good weekend. And thank you again, Dr. Zhang.
Thank you, Jason. Thank you, everyone.